Hey everyone, I hope you're all doing well. Today we're going to be talking about disorders of the biliary tree, some collies broadly is what we'll be talking about. I think they're pretty straightforward, but I think they can be a bit confusing in knowing what's what. So that's what I'm going to try and get to today. Very basically, gallbladder, it's pear-shaped, has a few parts, which is important to know the different types of collies. It's very straightforward. So this is the gallbladder here. There's the cystic duct, right? You then have the left and the right hepatic duct, which join from the common hepatic duct. The common hepatic duct joins the cystic to form the common bile duct, which then joins with the pancreatic duct later here. What you also need to know is that gallstones, because that's what causes most of our biliary pathology that we're going to talk about, can be stuck along any part of this kind of chain. And depending on where it's stuck and how it presents, we call it a few different things. The other thing that you need to know is this thing called Calot's triangle. Now, this isn't super relevant for anyone who isn't a keen surgeon, because surgeons love to ask you what the borders of the Calot's triangle are. And this is surgically, I guess, relevant. So the inferior border of the Calot's triangle is the cystic duct right here. The medial border is the common hepatic duct right here. And the superior border is the inferior surface of the liver. So this entire thing is called Calot's triangle. Now, why is this important? This is important to locate the cystic artery, because the cystic artery is the artery that supplies the gallbladder, right? And therefore, during a cholecystectomy, when they remove the gallbladder, they also need to be able to clip the cystic artery and clip only the cystic artery. So being able to make that distinction is really important. And that's kind of the only main structure that flows or passes through the Calot's triangle. Now, gallstones. So the gallstones that you need to know are the 5 Fs. So the risk factors for gallstones. So female, 40, fair, fertile. When I say fertile, it just means of like reproductive age. It's a stupid one. And then fat, obesity. So based on that, we can call gallstone pathology a few different things, right? Firstly, we have cholecystitis. That just means that the gallbladder is inflamed. Cholelithiasis means that there is a gallstone stuck somewhere, anywhere. Gallstone, anywhere in the gallbladder is just called cholelithiasis, right? The two aren't mutually exclusive, right? You can have gallstones that cause cholecystitis, but you can have gallstones that don't cause anything. We'll get to that in a second. You then have choledocholithiasis, which is where the gallstone is particularly stuck in the common bile duct. And cholangitis is a clinical condition that is because of infection and inflammation of the biliary tree. That presents with a whole bunch of triad features. That is called Charcot's triad. It presents with a triad of jaundice, fever, and right upper quadrant pain. And that is typical of ascending cholangitis. So let's look at that again. Cholecystitis, which is one of the most common surgical presentations, is merely inflammation of the gallbladder. This can be either because of a gallstone, in which case it's called calculous cholecystitis, or it can be because of something that's not a gallstone or without a gallstone. So cholecystitis in the absence of gallstones is just called acalculous cholecystitis. When cholecystitis is because of a gallstone, the most common place you'd find this stone would be the cystic duct, right? So most commonly when people have cholecystitis, it's because there was a gallstone that was in their gallbladder because of a mismatch in the bile salt concentrations. That's why gallstones are formed in the first place. And while the gallbladder contracts, one of the gallstones or a few of them got stuck in the cystic duct. That causes it to dilate, balloon up, get infected, and inflamed, cholecystitis. Cholelithiasis is just a gallstone in the gallbladder. So patients obviously can have tons of gallstones in their gallbladder, which doesn't even present with anything, right? So cholelithiasis just means that there is a gallstone. It doesn't tell us whether the gallbladder is inflamed. It doesn't tell us whether they're symptomatic. It just says there is a gallstone. If this gallstone was to pass through the cystic duct and then enter the common bile duct, that is when it would be called choledocholithiasis. So choledocholithiasis is particularly a gallstone in the common bile duct, which can lead to cholangitis. Now, in terms of clinical presentations, we'll touch on how all four of these can present differently, right? So let's start from the very top. Cholecystitis. Let's think of what's happening clinically. Most cases, as I said, you have a gallstone that's in here, gets lodged into the cystic duct and gets stuck there, right? What this causes, it causes the gallbladder to balloon up, get inflamed, which is why patients are often are Murphy's positive, which is the tenderness on deep inspiration. They have right upper quadrant pain. That's colicky, because again, when it contracts, it's contracting. When the gallbladder contracts, it's contracting against a blocked cystic duct, which is why it's contractile in nature, the pain. They can also feel really bad. They can have a fever. They can feel nauseous. If I were to ask you, do you think a patient with cholecystitis would be jaundiced? In most cases, what would you think? Take a second and think about that. When you do, I hope you would think that the bile that gets formed in the liver passes through the common hepatic, goes up the cystic, gets stored here, right? And then eventually gets pushed out into the common bile duct. If you have an obstruction here, you still have a free flow of bile through the common bile duct, and that's not obstructed because the obstruction is up here. And therefore, although the gallbladder won't be able to drain, you still have free drainage of bile. And as long as the common bile duct is unobstructed, you will not be jaundiced, because jaundice would only happen if there was an obstruction leading to the backflow of bile, which is not going to be the case here. Cholelithiasis, in most cases, asymptomatic, but again, it's not a very useful term to use. Choledocholithiasis, on the other hand, can present with a bunch of things. Remember, it is just pointing towards the fact that there is a gallstone in the common bile duct that is here. That can cause the backflow of bile up the common hepatic duct, up to the liver, and people can be clinically jaundiced. It can also cause a further backflow into the gallbladder, and they can also have cholecystitis. If eventually whatever bile is flowing up gets infected or inflamed, and the entire biliary tree also gets infected and inflamed, that can present with cholangitis, which is again that triad of not only is there bile flowing upwards that causes jaundice, but they're also going to be feverish because it's an infection now, because that bile flow is now infected bile, and they're also going to have right upper quadrant pain, partly because the biliary tree is inflamed, but also because the gallbladder can be inflamed. I hope that made sense in trying to distinguish what these basically are. And this is basically what I've already talked about. What you also need to realize is that, yes, technically you can have, we mostly talk about these in isolation, but you can have more than one of these happen at the same time, right? You can have cholecystitis with cholelithiasis, right? Because the two don't mean, they mean different things, right? So, however, in exams and in like a surgical ward round, if you see a patient with cholecystitis, you very rarely would say they have cholelithiasis, right? Because the presenting thing is cholecystitis. But that's more so a technical thing. That's just the practicality of what you call it. So let's go through a case and let's talk about how you would work through jaundice partly. I know we've done jaundice in another lecture, but again, talking about this kind of jaundice and how some of these cases can present. So James is a 46-year-old man who presents with a 2-day history of jaundice. He's otherwise well. Now, based on this, I hope you would automatically jump into your, well, firstly, I want to know everything I need to know about this jaundice. So your WWQQ, what, where, why, when questions, we need to get them out very like nice and easy, right? The second thing you need to ask yourself is, okay, he's jaundiced, and I know because I've been really paying attention in class that there are 3 types of jaundice: pre-hepatic, hepatic, post-hepatic. And my goal for the next 2 minutes is to be able to understand which one of those 3 criteria James fits in. And lastly, you want to also think, once you've done that, ask yourself what are the most common causes of jaundice and ask a few cluster questions for each one of those. So let's do just that. Firstly, we have a good summary of his jaundice, sorry. That is my issue. I had a different name and I changed it. Didn't change the pronouns. I apologize. So we go through WWQQA. We ask about pale stools and dark urine. Now, why do we ask this? Because a combination of pale stools and dark urine is very, very specific for obstructive jaundice. You would not see this pattern in either hepatic or prehepatic causes of jaundice. So he does say that he has pale stools and dark urine, and he also has an itch. The next thing we ask ourselves is, if this were to be a liver issue, is this acute, chronic? Is the liver coping okay? So again, talking about the temporal nature, how long has this been happening for? And then wondering, well, the liver does other stuff. It does coags, albumin, platelets. And how do we ask any of those questions, right? So you can ask about bruising, bleeding. Those would be just two questions that I would ask for this, although we already know that the fact that he has pale stools and dark urine makes this more likely to be post-hepatic than a hepatic cause. Next, we have the four most common causes of jaundice, and I'm going to ask a few specific questions for them. Firstly, we have hepatitis, particularly viral hepatitis. So asking questions, have you had in recent travel, food from outside, unprotected sex, drug use, tattoos, blood transfusions, and immunizations? These questions, in my opinion, are a really good hepatitis screen, which you always should be asking any patient who comes in and is jaundiced. And he says he has been having some food from ordering in food, but that's pretty much the only thing that he positively responds to. He then also notes that other causes of jaundice include alcoholic liver disease. He doesn't have a florid alcoholic history. You then also know you have cholangitis plus minus cholecystitis, because the two can happen together. And then head of pancreas cancers as another cause. And it would be good to ask about things like fevers, weight loss, night sweats, which would help tie the entire thing together. So he says that his stools are indeed pale. James is probably the only patient who checks his stools and therefore knows what color they are. The urine is darker. He has a mild itch, no neurocognitive changes, and this has been going on for 2 days. This is pretty acute. He doesn't have any signs of hypoalbuminemia, like swelling. His urine is not frothy. He's not bruising easily. He doesn't have ascites, no shortness of breath. And he doesn't have any signs of prolonged bleeding or incidental bleeds either. So this makes me think this is most likely to be a post-hepatic obstructive jaundice with no signs of liver damage that is pretty acute. And that's a good summary so far. He also had severe right upper quadrant pain that was previously intermittent but now constant. So he also reports a fever, nausea, vomiting, and loss of appetite. At this point, you can do what I think is like a good quality screen. So the questions to ask are the following. So right upper quadrant pain, pain after eating certain foods. I don't know, this is, sorry, my bad. And risk factors. So BMI, is he a female, old age, fever, weight loss, all of those. So, sorry, and then that was recurrent pain. That makes more sense. Yeah, so right upper quadrant pain was previously colicky, but now constant. He does have pain after eating certain foods, which makes me think it's most likely a biliary pathology. He has recurrent pain that was previously recurrent. Sorry, it was previously recurrent, but now constant. He's fat, not a woman, not female. He's old. I mean, old, 43, not that old, but middle-aged. And he has a fever with no weight loss. Now, does this sound like a quality picture? It kind of does. Like it makes me think that this is probably a biliary pathology. So firstly, when you think that, you need to think to yourself, do you think this is acute or chronic? Do we think his liver is cirrhosed? Does his bilirubinemia seem to be predominantly conjugated or unconjugated? Right? So I think we've conclusively said it's acute, liver not cirrhosed. Hyperbilirubemia seems to be conjugated. Hep question, he responded, again, recent travel, nil. Outside food, yes. Not much else. Oh, drug use, yes. Okay, for this case, let's just say that he does use IV drug use, because not everyone who uses IV drugs has hepatitis. Obviously, you can see that I changed the screen from one screen to the other, but I forgot to change the slides on one. Anyway, doesn't matter. Let's just say he doesn't have anything that's particularly florid. What investigations would you like to order? So this is stuff that I'd always order for kind of a jaundice picture, and you can add stuff on if you suspect particular things. So an FBE, LFT coags, a UEC hep serology, HIV, CMV, EBV, an ultrasound of the hepatobiliary tree or an abdo ultrasound, plus lipid profiles are things that I would do. Right. This is just a very basic. I don't want to go into depth of why you do each one, but I hope they're relatively self-explanatory. FB for leukocytosis, LFTs for LFTs because he's jaundiced, coax for liver function, UECs for electrolyte imbalances, hep screen explanatory, infective screen explanatory, and ultrasound explanatory. There's just duplicate slide. Okay, so based on the fact that this man has fever, he has right upper quadrant pain, and is clinically jaundiced, my most likely diagnosis is that of acute cholangitis, right? But that is just Charcot's triad. But based on that, how would you actually assess that clinically? So firstly, you have signs of systemic inflammation, like fever, leukocytosis, elevated CRP, cholestasis, so the fact that he's clinically jaundiced and he probably would have a high bilirubin when we do his LFTs, and finding on imaging. So a first-line imaging is abdo ultrasound, and I know Monash is notorious for asking, what is the first-line investigation? What's the best investigation, right? So first line is abdo ultrasound. The best conclusive imaging, if the ultrasound is inconclusive, is either MRCP or CT abdo with contrast. The contrast allows us to phase out the biliary tree, particularly to see there's an obstruction. You would not be asked to choose between an MRCP or a CT abdo. They're both equally good, but they are confirmatory test versus abdo ultrasound you would always do as a first line. You can't merely use imaging findings to diagnose cholangitis because, as I said, it's a clinical diagnosis which needs to have both cholestasis and signs of systemic inflammation. You also, in addition to Charcot's triad, have this thing called Raynaud's pentad, which is basically all three of these, plus hypotension, plus mental status change. And these are reflective of severe ascending cholangitis. Other signs that indicate severity would be coag derangement, meaning that the bilirubin at the bile has actually been so infected and inflamed that once it's entered the liver, it's actually caused liver dysfunction. Same thing with hypoalbuminemia, a very high bilirubin, if they have electrolyte imbalances, hypoxia, or end organ dysfunction. Any of those would indicate that this is severe ascending cholangitis. Treating cholangitis, you need to do two primary things and have two things that you need to do. I said the same thing twice. Sorry, that last sentence was very stupid. So urgent antibiotics, and your usual regimen for this would be AMG, which is a go-to for most gastrointestinal infections. So amoxicillin, metronidazole, and gentamicin. You also want to do biliary drain, so drain the infected bile, which is done for moderate to severe cases. In mild cases, antibiotics themselves may be sufficient, but in most tertiary centers, you would be draining the bile anyway. This can be done, it's most commonly done through ERCP. And so this is a procedure where we go through the stomach all the way to the second part of the duodenum, look, and there we have the ampulla of Vata, right, which is where the common bile duct combines with the pancreatic duct to drain into. There, what we can either do is we can perform a sphincterotomy, where we cut through that sphincter to make it more open, dilated it so that bile can flow more freely because there's an obstruction, right? That's why you have the backflow. Or we can put in a stent to, again, allow easy drainage of the bile through. That's all we had for today. Hope that made sense. And if you have any questions, please feel free to get in touch. And as always, please look after yourself and look after your loved ones.